Welcome back to the Chatty Vets Pod. I'm Brendan.
And I'm Charlotte. Thank you for tuning in.
Welcome to our first podcast of August, our next 2 week takedown episode.
This is where we aim to bring you up to date with all the latest news and products in the UK from the last few weeks.
We're spoiling you again this month. There's 5 Sundays in August, so we're bringing you 4 episodes, you lucky things.
You are very lucky. So look forward to an extra bonus episode at the end of this month. It's a big juicy one. The next of our Enteropathies series covering Addison's disease and the Addisonian crisis.
We can't wait, but let's not get too ahead of ourselves. Lots to cover before then. Before we dive into today's podcast, we wanted to reflect on the madness of last month and to update you all about our new thriving CPD stream.
Yeah, so last month we held our first ever live CPD event on New Grad Consult Survival Day. So this was a whole day of online CPD aimed at vet students just about to qualify and new graduates in practice. So we were basically trying to help them prepare for their first few weeks as a new GP vet and help them feel a little bit less nervous.
Yes, it's absolutely terrifying those days. I'm glad I've got those behind me, but it's a few years of kind of getting your confidence, trying to remember what vaccinations to give, when, flea products, worming products, what goes with what you're meant to do if someone walks in and has been vomiting for 24 hours non-stop, all of that stuff.
Yeah, it's really scary when you start off, isn't it? So we basically wanted to start off this CPD stream to see if we could help new grads just feel a little bit more confident before their first few weeks in practice. So we covered topics from how to approach a general consultation and communication skills with our clients, those bread and butter preventative healthcare consults, through to all the different common clinical presentations you're going to see, such as diarrhoea, skin and ear disease, and even the biggies like how to do with clients with limited finances, argumentative clients, and the dreaded euthanasia consult.
Yeah. Charlotte, do you remember like about 10 minutes before we started, I said to you, oh, how are you feeling? It's the very first time in my life you went, I'm actually quite nervous. And I was like, my God, Charlotte's actually nervous.
Yeah, I was.
And I was like, yeah, I'm fine, whatever.
And honestly, I'm one of those people that I can tell how I'm feeling with how my gut is. And I woke up that day and I was like, I don't feel okay. I think I was really nervous. Yeah. But no, we loved it. And it went so well, doesn't it? We're really, really chuffed. So
you didn't sound nervous one little bit. And it was actually one of the best things I've done for ages. It was brilliant. Yeah, I loved every second of it. And the feedback was just, it's another one of those things. Like, yeah, when you get, the feedback was amazing, wasn't it? Like, yeah, so many people said they just loved it. It's brilliant. Absolutely thrilled.
Exactly. I mean, we had to quote some of them because honestly, I felt like crying when we got some of the feedback responses. We got some of them were 10 out of 10, absolutely brilliant. Someone said, honestly, the best teaching I've ever had. I mean, I don't know if I would agree. I feel like probably lecturers are better than we are, but it's just so nice to hear some really lovely, honest feedback. We just didn't really know what to expect when we started this podcast, did we, Brendan? I think we just knew we wanted to produce something that was straight talking, fun discussions, and just about everyday life in GP practice. I don't think ever of us could have really have imagined the amazing responses we had. We just sort of wanted to take a second here to just say thank you so much to all of you for listening and to supporting us and to coming to the CPD day if you did, because it really does mean the world to us. Just, massive thank you.
Yeah, it's growing into something a bit special, isn't it? And I just thought it'd be a little private hobby, to be honest. I think you thought that too, Charlotte, didn't you? Because like the first 5 months, I look back now and I was like, Charlotte's not replied. It'd be like a month down the line. And I think you were just like, yeah, whatever, a little silly project. And then early on, you suddenly went, this is quite good, isn't it? It's quite a big thing. And I was like, yeah, it is. So it's morphed into something.
Yeah, absolutely.
Cool.
So, but I mean, just to sort of keep you guys in the loop as well, we mentioned briefly in our last 2 week takedown that we've now fully launched Chatty Vet CPD, and we're already planning a few more events later this year. So as well as our new graduate survival stream, we're also going to be launching an ECC stream, which I'm really excited about. So this is basically going to be all GP centered. So it will be called How to Ace Emergencies in General Practice. And we're very excited to say that the first event is going to be held on Thursday, the 24th of September in the evening.
I cannot wait. The first session will be covering how to approach dyspnea in cats. We're going to try and give you practical, real-world advice, how to approach the cases, how to work them up, how to treat them in a busy GP practice where staff are not freely available. You can't always do one-to-one nursing care. You might not have the skills or the equipment to do, everything that you kind of know you're meant to do. So it's kind of like the real life. And it's not always only clinical as well. It can be logistical and all sorts. So yeah, we'll try and guide you through it.
Yeah, absolutely. And the session's going to be completely online, so it should be accessible for anybody who wishes to attend. And if you're interested in attending, take a look at the link in the show notes. So we've attached the link there to the website where you can find out all the information that you need about the event and how to buy your ticket.
Yeah, the website's been evolving on multiple versions over the last 2 days as me and Charlotte hammering it out, getting it better and better. So yeah, I think it's looking pretty good now. It's some even better news. We've now launched our Chatty Vet CPD library. So every CPD session we run, we will be recording, and the recording will be available to purchase after the event on the CPD library. It's obviously nowhere near as fun as being able to come to the live event, interact and ask questions. By the way, Charlotte, on that question front, we had, 340 questions? Which I think we answered maybe 3/4. I don't know.
Yeah.
So we answer them live as well. As they come up, we try and answer them. So, it's just like the podcast. So we just kind of fly through. But so you won't have that option. But it's a great option for those of us with busy lives who might find it tricky to attend on the day. Right now, you will find the new grad, recent grad CPD. It's 7 hours. There's 4 recordings in total. There's course notes and there's all the slides. So that's all on there. It's £60 for 30-day access. So if you're a new or recent grad, people loved it. So yeah, you can give it a blast.
Yeah, absolutely. So if you did miss it and you feel like you've missed out, then don't worry. You haven't missed out too much. So pop to the website, links in the show notes, and you can have a little look back at what the day brought to us. So, okay, I feel like maybe we park CPD for a minute and we get into the podcast a little bit. What do you reckon?
Okay, yes, we're doing a random hodgepodge of different things today, from new medications hitting the market, a few recent papers that might change your day-to-day clinical practice, to something very exciting, a bit of a breakthrough for GI cases. That, I must say, a brand new test for chronic enteropathies. We did touch on this donkeys ago, didn't we? But we've got a bit of a special guest to help discuss it. And you know how excited I get about gut cases.
You love them. You love a chronic enteropathy, don't you?
Look, don't let that out, because at every receptionist, everyone gives me all the GI cases. It'll be too much and I'll have to give up working. But anyway, another thing I was going to, the kennel cough and pregnancy thing. What's your take on that? Because one of the nurses was asking me about this, and this is such a, go on, tell me, what do you say?
Well, I always was like, it's a bloody kennel cough vaccine. Like, they always say we need to be careful about it, but I'm like, really? Is anybody ever going to get Bordetella? Probably not. But then, do you remember me saying on the pod a little while ago that I had that lady that came back that was really angry at me because she told me that I gave her kennel cough? Do you remember? So
funny.
Basically, for anybody that didn't hear it, I had this consult, and I think I sort of sprayed it up the dog's nose, and at the same time the lady got a little bit of it on her hand. She wasn't immunocompromised, and I offered her to wash her hands in the room. She went, no, it's fine, I'll just wash it when I get home. I was like, all right, like, whatever, fine, I get it on my hands all the time and it's no biggie. Anyway, she came back like 2 weeks later and was like, you've given me kennel cough. And when you're like rolling your eyes like, yeah, right, okay. But I was like, well, what if I actually have given her kennel cough? So now I think I am a little bit more, I always had the immunocompromised discussion anyway, but I don't know. For me, I'm just a bit like, it's not a core vaccine. The majority of the time, it's a viral cough or cold in a dog. And I'm like, most of the time, they're absolutely fine. So I don't feel like it's an absolute necessity to vaccinate them.
How do you know most of the time it's a viral cough or cold?
Well, how many kennel cough cases do you come in? Do you see that come in and they're really, really sick?
Yeah, right. Okay. Can I get on my bee on my bonnet about this? Because, right. So hold on. Are you saying because it's not like a core vaccine, just avoid it if you're pregnant? Is that what you're going to say? Yeah,
because I just think, because surely we have to put human health up really high whenever we're talking about stuff like this. And I just think, if there's potentially a really small risk, then why do it? It's not like we're going to be vaccinating against lepto or distemper or something that could kill it if they get it.
So that pregnant owner's dog, let's say it goes to doggy daycare or kennels. Do you then give it the kennel cough vaccine, or do you not? Or do you say that there's a reason not to do it, give it a medical exemption?
Yeah, so I generally will say to the owner, look, it's completely up to you. You can give it if you want to, but being honest, I'd probably avoid it if you can. And then I give them the option to either do the injectable one, which they can do, or to call the kennels or the doggy daycare or whatever they say and say, I've been advised by my vet that it's not safe for my dog to have this vaccine. Are you still happy to take on those grounds? So just see what they say.
if it comes back from the kennels and it's got kennel cough, at that point, that's not an attenuated, weakened strain of Bordetella. It's now got the full force Bordetella infection. So is that pregnant owner meant to isolate from her dog? What does she do then?
Yeah,
or,
true.
What is a pregnant woman supposed to do in terms of isolating from other people, other dogs out there that might have kennel cough? Like, isn't it better to be exposed to a weakened strain of Bordetella in the vaccine, in theory? Because the truth of the matter is it's covering their back, isn't it?
Yeah.
Do you know, than the real thing?
Yeah, I mean, in theory, but then I guess you're still weighing up the fact that you're definitely giving the attenuated strain of Bordetella versus the chance that they possibly might get kennel cough by going somewhere where there's loads of other dogs. So it's a definitely going to be exposed versus maybe exposed. So I don't know. I just think we have a responsibility to have that discussion. Ultimately, it's that informed consent, isn't it? If they decide that they want their dog to have it and they understand the risks, then that's absolutely fine. If they decide that they don't want it and it may be, because the thing is you could give them a kennel cough vaccine and they get kennel cough anyway. And that's the thing that I would also say to the owners, it makes it less likely, and it's less likely to be quite as severe, if you want to call it that, as an infection if they do get it. But still, there's a risk that they can get it anyway.
If your immune system is so bad that you're going to get, look, bear in mind, every vet in this country exposes themselves to that vaccine every time we draw it up. Yeah. I mean, then shouldn't you, then you're at the level of immunosuppression where you should be isolating from other people who might have COVID, influenza, whatever, or isolating from other dogs that might be carrying like the real kennel cough or any other kind of pathogen. So if you're at that level, I get it. Yeah, definitely.
Yeah.
But most people aren't at that level where they're isolating from other. I think it's one of these things where you're far more at risk from another person than a dog that's been kennel cough vaccinated.
Yeah,
sure.
True. And to be honest, it's probably going to be prepping. So when you're talking about pregnant women, you think about when you have kids and they always come home with snotty noses and they've got they've picked up all these other infections from all the other kids that they're around all the time. So basically, maybe exposing them to Bordetella is basically like prepping their immune system for all the shit that's going to come over the next 10 years of their life, where their kids bring back all these horrible snotty noses and horrible respiratory infections. So maybe we're just like helping their immune system get building already. Moving on, because I know you're absolutely buzzing to start talking about it. So let's start chatting about chronic enteropathies.
Yeah, well, I do get angry. Yeah, you're right, actually. I get angry because, I always say this, but we just don't diagnose inflammation in the gut because we don't have a test for it. But we do now. But it's like talking to a brick wall, because every time you talk about it, people just blank over or they don't get it. But like, we have a test for inflamed bowel and it's a poo test and it tells you if the gut's inflamed. And, the study they did at Bristol was pretty damn good in terms of sensitivity and specificity.
Yeah. So we actually chatted to Lucy from Caris Animal Health recently. And she actually really piqued our interest about this new product that's come onto the market, and it's called GIQuest. So before you glaze over, have a little listen to this interview with her. It's really interesting, and we think this is actually going to make a big difference to people in practice. So here she is. We hope you enjoy it. So we have another lovely guest on the podcast. A big hello and thank you to Lucy for coming on with us today. Hi, Lucy.
Hi.
Hi. So Lucy is from Caris Animal Health. Now, Caris Animal Health, a lot of people might not know much about. So Lucy, do you want to give us a little bit of a rundown as to who you are and sort of how you got to this point and what Caris Animal Health is and what you guys do?
Yeah, of course. So I qualified as a vet in 2018 from Liverpool, and then I worked sort of in and around London in first opinion practice for about 5.5 years before transitioning into sort of the industry side. I then was a technical advisor for a nutraceutical company for about 1.5 years, and then I've been at Caris now for about a year. My role here is marketing and veterinary technical services manager. So yeah, Caris has been sort of around since I think 2017 or 2018, but very much in the research and development phase. So the first product we launched was GIQuest about just under a year ago now. So that's kind of the first one that's come out of the pipeline. So we've got a lot still going on in the background, but this is our first one actually out in the wild.
Nice. So for anybody, because I take it there's probably still a lot of people that haven't heard of it before and it's not really commonly being used yet. But what would you, if people don't know anything about it, how would you describe what GIQuest is?
So GIQuest is a point of care lateral flow test, which tests fecal calprotectin. So fecal calprotectin is a biomarker that is used loads in humans for like IBS and things like that hasn't really been used, certainly commonly within veterinary before. So fecal calprotectin is a protein that's found in various white blood cells, but we tend to just talk about neutrophils for ease. And it makes up around 60% of the cytosol. So when the neutrophils come into any site of inflammation and disintegrate, it releases the calprotectin to the surrounding tissues. So when it's GI inflammation, it's released into the lumen, goes into the fecal stream and can be measured in the stool. So it's a really clear indicator if there's that sort of specific GI inflammation going on.
Okay. I mean, I remember we talked about this, Brendan, was it one of the first ever podcasts we did? And you got so excited about fecal calprotectin, and I was like, I have no idea.
I have no idea
what you're talking
months.
about. Yeah. So yeah, because there's always been something missing in terms of our gut workups, and it's always been quite tricky to get owners on board with, because you get to the point and you're like, we know it's probably non-specific gut inflammation, we don't quite know exactly what's happening, but trying to get owners on board with ultrasounds and biopsies and all of the intense workup that we normally would be suggesting is quite tricky. So I guess a part of the reason why you got excited about this, Brendan, as well, is it seems to be like a really nice intermediate type workup to give you some information about what's going on and to get owners on board with doing that little bit more, point you in the right direction, doesn't it?
Yeah, I'm new to this test as well, but last week I had a cat that I had to sedate for, it's really poorly actually. I did my usual, which is, you can't get near the cat very easily, though the cat's got a lot better. But I said, if we do the test, let's do them all in one go. So I did some sedate, scanned abdomen, did a blood test. Blood test included PLI, B12, folate. Like that's like my standard, any cat with a bit of weight loss that's where I'm going to go. The bowel was thickened. So that for me is normally like it's an enteropathy. We've got a gut disease. But what was really cool about this one, I did a fecal calprotectin. It was up, and the woman was so cool about doing another poo test because the cat's so stressed. She goes, no problem. I can get the poo at home and we can recheck the poo to see how things are doing on the numbers. Because with cats, it's not always easy to track how their guts are doing. So yeah, that particular cat it's just superb. Yeah, it's another tool, but I've noticed that we've got it in the clinic. The other vets, there's a barrier to using it. I don't know if it's because it's poo. If it was a blood test, I don't know. It should be easier, shouldn't it? Because it's less stress to the animal. Why is that fun? I don't know. If it's a blood test, I'll just go, we'll do the bowel blood test. But because it's poo, I don't know. It's like a bowel test using the poo. Like, why is that a big deal?
I think it's just such a new concept, isn't it? And I think we all in our heads have probably because of our personality types, if we're in this profession, we have quite strict in our heads flowcharts of what we're supposed to do, what we are supposed to do next and when. It's partly that this is a new behavior for us. It's a new biomarker. No one's heard of it unless, funnily enough, they have IBS themselves. Then they're absolutely thrilled. We've had quite a lot of vets that have been like, I use this. I've wondered why we don't. So that's kind of part of it, is just that remembering. And I think it's also harder for us to change behavior when it can be utilized in so many areas, because I think it would be easier if we, in our head, had that diagnostic flow and said, okay, this point is exactly where we would use GIQuest. But actually, the whole thing is there's arrows going in. If an owner needs a bit more convincing, you could use it here as an objective. Yes, there is active inflammation. If they don't want to go for an ultrasound, but you want something that you can then monitor if your treatment or empirical treatment or diet trial is working, this is where you can use it. There's so many different points. Or the value of a negative test is the GI kind of area where I should be looking at the moment with this unknown grumbling something that's going on. And so I think that's the thing that's just harder and is that barrier, is that you have to understand the concept so much more to then be able to fit it in where you think it's needed for that particular case. Like you said, we recently were at a cat conference, and that's where everyone was like thrilled, because cats get very stressed coming to the vets. especially for follow-ups. And if there's a way that owners can just bring a sample in, they may not even need to bring the cat in, obviously, depending on the case and the situation. If it's for a checkup, it's massively helpful. But yeah, it's interesting you're saying if it was a blood test, you kind of think about it and do it then and there in the practice, rather than having people come back with the sample and it's an extra kind of thing. But we do have now clinics saying, come in with the sample, come in 15 minutes before, you know, and we can run it and we know where we're at to start that consult if it's something that's come a few times. So yeah, it does make it a little bit of a barrier when it's so new as a concept.
It's just getting people's mindset around it, isn't it? Because I mean, you know, if you've got a dog that's got crystals in its urine, or you have something that's got a UTI, none of us hesitate to go start on this medication, bring a urine sample in 5 to 7 days, and we'll recheck it and see how we're doing. So I don't know why. It's just getting people's mindset around it, isn't it? And in terms of the actual test, does it kind of work like, you know, those like Giardia tests you can use in-house? Is it kind of similar to that? You just use a little bit of poo and it's just like a point of care test that you'd use in-house?
Exactly. It's super simple. So you just, the amount of poo you need is so small. We've had loads of vets that if they're doing like a rectal anyway, just use what's on their glove. Like that's how little you need. And then you just like put it in a reagent, give it a shake for a couple of minutes and drop it on the normal lateral flow, which we're all very used to now. So, and then you just wait 15 minutes and it comes up with the control line and the test line. And the test line is a color gradient. And you've got a card where you basically just hold the card above it and match the color and then read across to the number, which is why you can then use it because it's semi-quantitative. You can then use it to monitor. It's not just, yes, there is inflammation or no, there isn't. It's 0 to 10. And for dogs 3 and above is abnormal and cats 2 and above is abnormal. So that's kind of why we can use it not only as a help to an aid to the diagnostic process, but also as a monitoring tool as well.
I've got another case. It was a young dog that's been on 4 different diets. Every 2 to 4 weeks, maybe a little bit more sometimes, it has these bouts of gurgly tummy and some GI signs. But in between times, she's really good. So do we try a different food? And she's already been through loads of food trials, and 95% of the time, the dog's great on this one. So I said, let's do the poo test. If it's normal, stick with this food. It might just be like, you know, we haven't got evidence for a long-term inflammatory condition in there, and we'll stick to the food, just see how things go. And she's just using Buscopan for these gurgly tummy episodes. And it came back negative. And I felt like, okay, let's not put the owner through, because every time you do a food change, there's like that, is she going to be worse? You know, especially if you've got a dog with gut issues, you're really worried. I thought that's a great way to, just to work out, give us a little bit more evidence.
Yeah, we've had a couple like that, funnily enough, actually. That's just reminded me of a case that we had where a dog had food responsive enteropathy, was doing fantastically on the diet, and then just had what seemed like a flare up. But it was also, I think it was sort of a cockapoo or some, you know, quite worried dog. And so had quite a few behavioural concerns. And they were worried that it was that the food was no longer working, but the vet had quite a suspicion that actually I think we need to go down the behavioural route. It seemed to happen when something happened in its life. So they did the exact same thing and tested when they were in the middle of this sort of flare up, and it came back negative. So they've now gone down the behavioural route and the dog's doing way, way better. But like you said, if they hadn't have had that to test, they probably would have changed the diet. And like you said, they often have quite serious changes when you change diet. So it's so useful to also help that communication with the owner in any diet trial, in any chronic GI case, to be honest. That communication is so important. I'm sure you guys are the same. The amount of second opinions I would see where I look through, you know, and think, yeah, I'd have done the exact same thing that they've done. The communication hasn't been there. And so owners come to another vet to say, I don't think this is right. We're on our second diet and they're really expensive. We've already done all these other things. And I was almost always saying, yeah, I would have done the exact same. Nothing's gone wrong here.
Yeah.
It just is so hard to get them to do the diet trial. We've had a couple of vets. One vet the other day described it as his cheerleader. So he has been doing it beforehand to get that baseline. So let's say, for example, they come in, you think probably we need to do a diet trial, which now is what they recommend, often prior to biopsies. I think the new ACVIM consensus said like up to 3 diet trials before you get to that point.
Wow.
Which I mean, trying to do one diet trial is a little bit of a struggle, let alone trying 3 different ones. And I think they said that's when you could maybe add like probiotics or prebiotics, etc. But he gets that baseline and then tends to retest around the 2-week mark. And even if it's gone from a 5 to a 3 in a cat, for example, and 2 and above is abnormal. So yeah, you're not completely normal, but that's such an easy way to communicate with an owner. We were a 5, we're now a 3. We want to be a 1 or below. But at that 2-week mark, that's always where I would get them come in and say, I just felt bad, so I put a bit of cheese or I put a bit of chicken. That's where you really need that boost to say it's working, keep going. And being able to communicate that with them at the times. Yeah, it's really interesting how we're getting the feedback of, oh, I'm using it here. And we think, oh, that's a great way to use it. So it's nice getting that back from the vet.
Going back as well to that case with the intermittent GI signs, you don't always know if the food change has helped or not because the signs are so intermittent in some cases. So that was really another reason why I thought, let's do the GIQuest test. If it's up, we've got something to monitor things by, because this dog can get quite bad at times and then in between can be quite good. So I thought if it just happens to be having a good phase, we won't know if there's really much of an impact.
Do you think, Lucy, those cases that come in, and typically it's normally like your cockapoos that are quite anxious anyway, and they've got itchy skin too, so they've got bad ears, they nibble their feet, and they generally have like intermittently horrible poos as well. And you're like, right, okay, I know that allergies are probably a part of this, but is it food? Is it environmental? And then you're stuck with like, I'm never going to be able to get them to do a diet trial because they just let this dog eat anything. It's really, really anxious, which doesn't help with the poos as well. Plus, you can go down the route of allergy testing with your bloods, but then you're like, oh, is the food allergy testing, like the blood's going to really help me? Do I just hydrolyze? What do you do? Do you think that's a point that GIQuest could be used to say, this is food related, this probably isn't food related? What do you think it's got to play in that sort of case as well?
Actually, the referral practice approached us with the exact same question. The dermatologists were thinking like, could this be used to like differentiate between CAFR and primary atopic dermatitis? They said we're going to run a pilot trial initially because they said the complicating factor is a lot of primary atopic dermatitis dogs also have chronic inflammatory enteropathy. So being able to then love that for us, but that kind of being able to differentiate really clearly, we're not 100% sure. So we're running a pilot to assess, because again, at the moment, with the amount of information we know, that's where a negative test would be useful, because we know that there isn't any GI inflammation going on. So I'd be much more likely to go down the route. The issue, depends how we see it. Because if you then do see there is GI inflammation, whether that is linked to the skin or whether it's CIE, you're going to do a diet trial anyway. So I guess that is kind of the positive, but being able to differentiate between a CAFR dog and an atopic dermatitis with concurrent CIE is going to be difficult.
CIE is
chronic inflammatory enteropathy. So it's what we used to call IBD. It's quite annoying because the nomenclature has changed millions of times. And so you have this umbrella of inflammatory enteropathies. I don't know if you've seen that, the like pyramid. So you've got the pyramid where the inflammatory enteropathy is basically split into different enteropathies. So you have food responsive enteropathy, which I think is normally around 60% odd, but I think in some papers up to like 88% have some sort of positive response to diet change. So at the bottom of the pyramid, you've got food responsive, which is most animals, which is why they now recommend diet trials prior to maybe some of the more invasive procedures, depending obviously on how bad the case seems. Food responsive enteropathy, you have what used to be called antibiotic responsive. but now they've changed it to microbiome modulatory responsive or something like that. So that also includes like probiotics, prebiotics, fecal microbial transplantation, and in some cases, very specific cases, antibiotics, but they didn't want, to say they're all antibiotics now. And then you've got like immunomodulatory responsive, steroid responsive, and then non-responsive to any of it. Okay. And it basically, that's under the umbrella of chronic inflammatory enteropathy. But then also, confusingly, they now also use chronic inflammatory enteropathy instead of us saying IBD, because I think in first opinion, it's still probably easier for us to say to owners IBD because they get it. They just understand what that means. But in the literature and the kind of scientific papers, they're not normally using that term anymore because it was getting confused with the human condition. And I think the way the disease works is different. So they didn't want it to seem like it was the same disease when it's different. Part of my job to read papers and be up to date. But all my friends that are still in first opinion practice, like it takes, I think someone told me the other day, it takes at least 5 years for a new paper or new concept to trickle down into first opinion. And so we're always going to have this like kind of knowledge gap. So they're confusing, and that's why these cases are confusing and they take a while. And we feel we have to work through so many different diagnostic tests, which makes owners frustrated. It's a lot of money, which is a big issue nowadays. There's just, like you said, there feels like there's been something missing that you could do at a low cost in practice to just give you a bit more information when maybe you can't take those next steps, or maybe you need backup to do those next steps.
In terms of when you're saying about, because we all know that gut workups generally are quite expensive, and that's part of the reason why owners are like, about having to go through with any of it. In terms of, I mean, obviously every practice is going to charge tests slightly differently anyway, but in terms of generally how much you're looking at GIQuest to be, is it just something that's quite reasonable that you think most people would be able to afford keeping check back on their animals fairly regularly every month if we were to recheck a test? Do you think it's quite affordable in that way?
Yeah, I mean, as we said, it is so varied as to what practices charge things out at, and if they've got like lab fees and stuff, although normally they're not charging lab fees on this because it's a lateral flow, so it's not within that class. On average, I do massive asterisk average, it goes out to clients around £50 or £60. So really affordable. Okay. We sell it to the wholesalers who sell it to the vet practices. So it is very much a case of like, we just try to keep our costs down as much as possible, because the whole point is this is a monitoring test a lot of the time. And if a client is needing to do it multiple times, we wanted to make sure it was affordable and approachable for clients and for vets to feel okay recommending it multiple times as well.
Yeah.
In the practice where I work, clients don't even blink at the price. And I think that's partly because for a lot of clients, it's more about the stress to their pet. They just jump at it because, it's easy. It doesn't involve their time. They don't have to bring the patient to the vet and collect. Yeah. So I think that actually has a bigger impact on the client's willingness than the cost almost.
Yeah.
And the other options are so expensive. So
going back,
Lucy, what you said, I am slightly excited about this pyramid because I'm going to start using it. So, essentially, you've got things you can affect with prebiotics and probiotics. And then we've got a large, massive group, which I think is always underestimated over the years, of food responsive enteropathies, which is diet change. And then you've got the potentially smaller group of drugs, ones you need drugs like steroids, prednisolone for, right? But am I right in saying along that whole base, fecal calprotectin would go up most of the time?
With all those types, because there's an inflammatory element, you will see a raise in calprotectin because they're inflammatory enteropathies. So you're going to be seeing it with each of those. So that's why getting that baseline is so important. We've certainly had a lot of vets that when it's come back, let's say for a dog where 2 is borderline, 3 and above is abnormal, the next step would have maybe been endoscopy. The owners really don't want to do it or can't really afford it. And actually it's come back as a 2. They might be a little bit less like pressurizing about it, or just thinking, okay, let's recheck in 4 weeks with this empirical treatment and let's see how we've got on. If it's, an 8, that may be more of a concern. Now, again, we have had, that's not to say it's something like in cats, we keep getting this question, of course, can it differentiate between old school IBD and lymphoma?
Everyone.
And we're like, well, we would be screaming about it if we could, but because obviously, I mean, now they're thinking that actually those can be a continuation of the same, and it can be a continuation of the same disease. So at what point do you say we're at one versus the other? And we haven't. I don't think you would be able to do it reliably, but we have had a few instances where they've started on a steroid and the GIQuest has been high. They've started on a steroid, rechecked 4 weeks later, and it was still the same. I would be a lot more concerned about that. And actually, funnily enough, in all of those, the clinical signs completely resolved. So if you hadn't had GIQuest, you'd think we've cracked it. And that's then where they can turn to an owner and say, I even more so think we need to go to an endoscopy and biopsy at this stage.
Yeah.
And it may be an absolutely horrific IBD, CIE, whatever we want to call it, but it might not be. They have actually ended up coming back as lymphoma, but we've not done the studies to be able to know at what point. And I don't think you ever would be able to say at 5 and above. It's more like they think now it might be a continuation of the same disease. But it does aid you in understanding, is what I'm doing changing things? And if it's definitely not reducing inflammation when you're giving a steroid, I would be more concerned. And owners are much more likely to take that concern on board because you've tried something and you can show them, I know your clinical signs you're seeing have reduced, but this hasn't. And so I think that's a big thing but it's always got to be histopathology to properly differentiate.
Yeah, can I get a bit ranty about this? Because how many cats do I see? They go, oh, it's like GI lymphoma, and they want to euthanize the thing. And I have treated so many cats for years on prednisolone alone. Sometimes I throw in chlorambucil for years, and if they've got GI small cell lymphoma and severe IBD, just the same. Don't get excited about it. Just shut the hell up. It really pees me off when people go, can it tell the difference between IBD and lymphoma? It doesn't matter. The cat owner doesn't care. The cat doesn't care. Give them the steroids and see how long they'll go for. You'll be really shocked. Honestly, they can go on for years. Years on that protocol.
Small cell lymphoma, some of them can go in remission. Like it's not always the case. I think we're often really nervous in practice to use something like chlorambucil, just because it's like as soon as you start discussing with an owner that it's chemo, they think they're going to have like a bald cat that's vomiting all the time. And it's just like, because we imagine what humans have. And I think it's just one of those things where we just have to think about, like you said, what actually is it going to change? And that's also what I say about all diagnostic tests. What's it going to change? Are we changing our next step? If not, don't do the diagnostic test. Because if it doesn't change our next step, we shouldn't be doing the diagnostic test just for our information. It needs to be that it alters our next step or our next pathway or aids in our communication and client understanding. That is a big part of it. But a lot of the papers say the exact same as you now, that a lot of people are thinking, at what point do we need to differentiate, or do we just give the treatment and go from there?
Yeah. Going alongside that, historically, because I do a lot of abdominal ultrasound, I measure the bowel, I see thickening, there'll be a huge muscularis, the bowel will be really thick. And what I used to do is I'll get them back for a scan about 1 month down the line after prednisolone, and the bowel will often be normal again. So that would be my way of kind of going, oh, this is doing pretty well. And then I progressively drop the dose. And if it has a flare up, the odd times I have rescanned, it's been thick again. So I've used that. I can't help feeling that fecal calprotectin is going to be my initial go-to now. It's still early days. I'd like to see how it responds, but that's going to be much more palatable to the owner. I think, and cost-wise, it's going to be way better. So as I'm doing dosage reductions, maybe a week or two down the line, maybe 2 weeks after a dosage reduction, do a fecal calprotectin rather than get the cat in for a scan.
Yeah, we've got loads of people using that in multiple kind of types of inflammatory enteropathies where they're using it. They get that baseline at the ultrasound. Actually, funnily enough, also some then come back as 0, and they're thinking, thinking that thickening might have been from a previous something or other that's happened. They don't have active inflammation at the moment, and our sensitivity and specificity are like 94 and 96 in dogs, and like 92 and 100% in cats. So it's pretty good for a lateral flow test. So you can be relatively confident in the results you're getting. And so if you're doing that scan, get that baseline, see what's going on at that point. You then have that to refer back to. And then, retest once you've started it. Of course, you would expect that to go down to normal if you're using a steroid and it is steroid responsive, and that's the point of it. But we've certainly been having people use it that have then caught the breakthrough flare-ups when they've reduced doses and been able to be like, oh, quick, get them back on before they've actually seen any clear clinical signs. So that's definitely an area people are using it in for sure.
Yeah. So, I mean, it definitely sounds like GIQuest is at the point where we can see the usefulness of it and how it is going to slowly be moved into practice. But I think, like you say, there's still studies undergoing as to all the different ways that it could be used. I mean, we have a lot of RVNs and a lot of new grads that listen to the pod and might be going, oh, I'm not quite sure how I might recommend this to clients or how I should be discussing this in practice. What would you say at the moment from the evidence that you have? Where do you think it has its most usefulness, if you like, in sort of your day-to-day cases? Is it those sort of monitoring your food trial cases and your diagnostic? Is it about inflammation or is it not? Is it those sort of cases where you think that's where you'd start introducing it and then basically see where the evidence takes us as to all of the different types of cases that we could be using this for?
Yeah, so in the validation study that was done by Bristol University, they basically did it in a couple of areas. So assessing if it can tell the difference basically between normal, whatever normal is, and chronic inflammatory enteropathy in dogs and cats.
Okay.
So certainly that is to assess if there's active inflammation. So anytime you're questioning, is there inflammation in the GI tract happening, this can obviously be used as a yes or a no. As I said, those negative results are sometimes just as useful. And then they also did in dogs testing for food responsive enteropathy, pre and post a diet trial. And then they also did NSAIDs, which we've not mentioned, but actually using them, GI side effects are the most common side effects of NSAIDs. And we don't monitor them when they're on them long term for OA. We monitor kidney, might be monitoring liver. And this is a way we did the NSAID in 20 dogs, went on NSAID for 2 weeks, and they were tested pre and post. Quite a few of them, I think it was 25%, went above the abnormal inflammatory range. Whoa. So that's when, again, that's then going to facilitate your conversations with owners as to, do we need to maybe think about the NSAIDs we've got them on? I think most of them were meloxicam because it just was going to be what they were put on anyway. Do we need to have a discussion about COX-2 selectives? May that be more GI sparing? Do we need to talk about multimodal analgesia so we can add in another analgesic and reduce the NSAID dose? Do we just need to keep a closer eye on them? Do we need to maybe think about, any other modality or treatments we can give? So that's another area it's being used in nurse clinics when they come for those checkups as well. Yeah. But again, getting that baseline is really helpful for that as well.
Yeah. I think that's so interesting because, I mean, how many duodenal ulcers or whatever have you seen where these dogs have been on these sort of medications for so long and then the sort of owners haven't really noticed, and then it starts to develop some horrible inflammatory issue that's happening. You get ulceration, then you get all the drama that comes with that as well. I think that's such a nice thing to be able to add in and be like, no stress. It's not like you have to come in for another blood test. It's just give us a little bit of poo. We'll just make sure it's still the right medication for them. Like you say, it's another string to the bow of why it's going to be so useful.
Yeah, and showing owners that we're being proactive with NSAIDs. They've all gone on Facebook and seen some horrid stories about whatever, this is done. And I certainly know of cases where owners have just come in and they'd read something on Facebook and they just stopped giving it because they were so worried. And it was 2 months before they came in for their recheck. And actually, if we're showing them we're being proactive, we know this could be a concern. We know this could be a problem. So let's check it. And, there were, I think, 5 or 6 of those dogs that didn't change at all in the 2 weeks. That would be really confirming to an owner, where a lot of owners have had, concerns, or they've had animals on these drugs before. They know much more about it and are a lot more concerned because it is a long-term drug that we're putting them on. And it is necessary. They're fantastic drugs. They're brilliant analgesics. We are absolutely not ever saying don't use them, but we can be more proactively checking the GI tract now.
I've got a burning question that I've been withholding all this time. Right. So when you have because sometimes you might think there might be a long-standing gut issue, but they're having, let's say, an acute flare-up, or let's just say they haven't got a long-standing gut issue and they have an acute GI incident, vomiting and diarrhea. How does the calprotectin go up during temporarily in an acute upset tummy, and then it makes you think it's got a long-term problem? Yeah. Or is it only a test of long-term inflammation?
We always say use it in chronic cases because that's where the evidence is, and that's where it's utilized in all the studies that have been going on sort of for the last 20 odd years, I guess, in the background of veterinary. Wouldn't really recommend using it in acute because I don't think it's super helpful, because it's if it is super acute, there probably is going to be some form of inflammation, and it might raise really high and it might go down really quickly, and it's not really going to massively help, because a lot of acute cases, we know what we're going to do with them for that first few days. It's when it gets to sort of the 3 weeks or more, and that can be 3 weeks, as you know, of intermittent, that still counts as chronic. So it's the chronic cases that I would really be using this in, because I think, especially with the acute, as we said, my question would be, what will it change as to what we do? And probably it wouldn't change that much. So just from that sort of very much my vet hat on, I wouldn't probably use it in practice in acute until or unless we get more information about it in acute.
And I had one more question. I don't know if you would be able to answer it as such, as it might be one of those nuanced things, but the standard cockapoo thing where you have the anxiety and those sort of behaviors that come in with a potential food enteropathy, for example. Say you use the calprotectin, you said, okay, we think it's likely food enteropathy. You start them on a right diet, the calprotectin comes back down to normal, and you think, great, they're being really well maintained. They have a flare up and you're suspicious it's related to, I don't know, someone going on holiday for a couple of weeks and they're staying with other people and they're highly stressed, etc. And the owners notice that they're having a flare up, their poos are getting worse, they're not eating as much, blah, blah, blah. Is your calprotectin likely to be higher in that instance, in those cases, because of a stress-related inflammation, if you like, or effect on the gut?
So again, this is an area that we've actually ended up learning more since people are using it in practice. So we really want to we're in a couple of talks at the moment about doing this more as an official study, because we kind of hadn't really thought about it from a behavioral sense. I guess we were so focused on the chronic inflammatory enteropathy that you think, they all have behavioral issues as well, don't they? And funnily enough, one of the case studies someone sent in to us about a case they used it in. This was a cat, actually, but very behaviorally complex, shall we say, cat, who the owner just often had to go away for work and various illnesses in the family. And this cat kept having various flare-ups, but they knew it had food responsive enteropathy. And the owner was away. The cat had what seemed the exact same signs as when they would normally have a flare-up. And they did the GIQuest test and it was normal. And so they felt good, because this cat was super fractious. And so they ended up getting to the point, because the owner couldn't pill it anymore. They just had to give a steroid injection anytime that it had a flare up. This time they could take stool sampling without the cat coming in to assess it. Now, owner did end up coming back and felt bad for being away, gave it a Shiba pouch, which then there was a flare up. They then retested and it had gone up to a 6. So that was a very clear GI inflammatory flare up. But when it was when they were away, it was their normal. And again, that's why it's so useful to have that baseline. So I can't say for sure, because there is some literature that says dysbiosis can increase fetal calprotectin, and dysbiosis obviously can be caused by stress and behavioral issues. But yeah, they have certainly been using that in first opinion. It's more just I'd like to know for sure to be able to say like definitely or definitely not. But that in that case, it was super useful because they didn't end up giving it a jab of steroids that this sort of 15-year-old cat didn't need. So we have been getting feedback, but I would love to look into it more for sure.
Very quickly, I really need to say this. That is big news that you slipped into the middle of this. You said ACFIM consensus statement is talking about 3 food trials before you go to endoscopy and biopsy and all these things, which frankly most owners don't want to do anyway. And so if we're doing 3 food trials, then that's where the fecal calprotectin is coming in even more useful, because before we start doing all our invasive things, we've got a really neat thing. An owner's going to be like, well, I can pay £90 for or whatever for a fecal calprotectin test, because this is, hopefully I won't need to do the £2,000 biopsy.
Yeah.
So it's even more important, isn't it?
Yeah. And I will say that paper is unbelievable. It's so detailed, and they have a flow chart at the top that is so complex that it's sort of slightly mind blowing. You've kind of got to pull out what you want from it from a first opinion practice, but at least then you know what they're recommending, and kind of I know we don't like to call it this, but the kind of gold standard would be, and then we can start deciding, depending on the case, depending on the sort of that contextualized care we have to do with every single patient, whether it's finances, whether it's that they're fractious, whether it's the owner kind of relationship, etc. We can then pull the bits we need from that. But it was 3. I thought when I saw 3, that's really hard to get people to do in first opinion. And actually being able to set the expectation that we are recommended to do 3 is really useful, to be able to say that at the start. So you're not going on to the first one, and when you need to try a second, they go somewhere else because they don't trust what you're doing.
Yeah, and like you say, if you can see that the calprotectin, say at the 6-week mark, has come down a little bit but not enough, that's enough for you to say to a client, don't keep carrying on for another 2 to 4 weeks. Let's move on to something better, because we will better for your animal, because we know that this is working. It's just not working well enough for your pet. And then it saves you that extra ag of being like, just keep going. We think it's working. It just needs a bit longer. And then you're losing more and more client trust the longer you go on. And it gives you that impetus to say to the client, like, no, keep going. This is happening. We are getting improvement. It's just not as much as we want. So great. And so obviously a lot of people that will be listening to this won't have had a chance to use GIQuest yet, or have known, or maybe not even heard of fecal calprotectin before. If people wanted to try and start using this in practice, how can they get in touch with you? Is it through wholesalers, or is it getting in touch with you about lunch and learns, or how can people sort of get in touch and start to see if they want to use this in practice?
Yeah, so it is in all the kind of usual wholesalers, so MWI, NVS and Covitris, so they can just order it through their normal wholesalers. But if they do want more education on it, so a lunch and learn, etc., or like a coffee, whatever is best, they can contact us. Our website is carisanimalhealth.com, or if they just search GIQuest on Google, it'll come up. And we've got sections on there to contact our business development managers, and we've got a few contact forms, but also we've got a resources section, which they might like, which has different articles on feline chronic inflammatory enteropathies, canine, food responsive, etc., and a couple of webinars, podcasts, etc. So lots of education on there as well.
Great. Okay, great.
For someone like me, right, I've been banging my head against a wall with cat GI cases, chronic enteropathies for 20 plus years. I can tell you every practice is missing, probably every 5-vet practice will be missing 1 case a week minimum. They'll be missing it, and that cat will be going on for years with its stable GI symptoms, because they'll usually have stable GI symptoms for years and years and years, and there'll be a proportion that are dying every month in a 5-vet practice. I guarantee you're missing them, and you're missing them because for vets, you're not running a B12 folate, and you're missing them because you're not doing abdo ultrasound and measuring your jejunal thickness and looking at your jejunal layering. So this test, this non-invasive test, is like vital to pick up on those chronic enteropathy cats that are being missed in practice. Like it's that important.
Yeah.
And it's a crying shame. How many times I have had 5 cats that have had chronic GI symptoms for 20 years. Over the age of 20, I've changed their diet and their symptoms resolve within 2 days or 1 day.
I think you're right. I think a lot is missed. And I do think it's specifically with cats because there's a litter tray that's easier to clear up. So they're not coming to us because it's affecting their life as much. Or people just think cats vomit. They just think that they vomit.
They do.
And that's
or they're just not seeing their poos because they go outside and they've got no idea what their poos are like.
Absolutely.
Yeah. I think this would also be really useful for, I mean, we were doing it yesterday in the CPD we ran, Brendan, weren't we? We were doing like a how to approach the not quite right consult. And you see that so often where people come in and they're like, they're just losing like a little bit of weight. They're not eating quite as much as they were. They're just losing a bit of condition. Something's just not quite. And you do a clinical exam and everything feels and looks pretty okay. This would be actually a really nice thing to add in at that point to say, okay, you've done a full heme and biochem, and you've maybe done it but it'd actually be quite nice to check a poo sample in this way and say, is there any element of any bowel inflammation that's a part of it at this point? Because if it comes back as negative, you're like, great, I probably don't need to do a big abdo ultrasound and check the gut.
Yeah.
But so it helps to guide you in the direction you're going to go, because otherwise your bloods are normal and you're like, bit of a fishing trip, like where do we image next? Whereas if your fecal calprotectin is really high, you're like, great, we know the bowel is involved, how is it involved? But then you know where you're looking. So I think it could be really interesting in those kind of cases as well, where you've not necessarily been pointed in the direction of gut from the history, but the test is helping to get you in the direction you want to go to. All right. Well, thank you so much, Lucy, for joining us today. We really, really enjoyed the chat. And I think hopefully everybody that's listening will have enjoyed it too. And what I'll do, if it's okay, is I'll ask you to send me their links that we can put into the show notes. So if anybody's interested, they've got all the links of how to contact you and how to get some information. So that'd be great if that's okay.
Perfect. Yeah. Thank you so much for having me.
Well, you're so welcome. Thank you.
Hey, that was such a cool interview. I think that was, it's a funny old thing to get your head around because there's so many different uses for it and it's not like anything we do already. So yeah, I thought that went really well.
Yeah, really well. And a massive thank you to Caris Animal Health for sponsoring this episode as well. As we said in the interview, if you're interested in finding out a little bit more about GIQuest, the links are all in the show notes for you, so do have a little look. So there's actually a couple of really exciting advances that are coming into VetMed at the moment, which is basically I really want to talk about. So there's been a new development in feline medicine recently, and there's a new drug out for combating the non-regenerative anemia in chronic kidney disease cats. So I think we all know those sort of cases where you've got a cat that's come in, it's been losing a bit of weight for a while, it's just not quite itself, you check its bloods, it's azotemic, you basically have got to the point where you've staged it and you've thought, okay, it's iris stage, whatever, it's got chronic kidney disease. But then it's sort of been battling it for a while. You check its PCV and it's like 20 or below, and you know you've got this chronic anemia, this non-regenerative anemia, which we know is probably causing a significant impact on their life in terms of lethargy, energy levels, etc. But I think a lot of the time in GP practice, we sort of don't really know what to do about it. And there's been nothing previously licensed for us to be able to try and treat that chronic anemia in these cats. There's stuff that potentially you could use, but it's always been off license and really expensive.
Yeah. I'm just thinking back. I feel like it was more popular to use that EPO injection. I don't think I see it as much anymore. I don't know if I'm not in the right practices, but EPO was all right once a week. And I mean, I'm glad you said below 20 because when do you, like, I think the latest iris was like it's over 25 hematocrit that you're meant to think about drugs for anemia. But to be honest, if I had, I don't know, it's tricky because some of these cats are like 18 years old and the owner's not really wanting to embark on the really hefty stuff. But in the right case, if it was low 20s, but definitely high teens, I'd probably be wanting to do something. But it's not very palatable, is it? All the monitoring, injections, that's the thing.
I mean, I never even saw it done before I moved to the practice that I'm at now. I just hadn't seen it used before, really. And I think it can be really difficult to get owners on board with the management that we use all the time for chronic kidney disease in cats, you know, trying to get them on board with blood pressure measurements, getting their protein checked all the time, you know, basically having rechecked bloods quite frequently, and to get them on board with the diet and all the other medications that we can use already. Then trying to add in this thing about anemia, it can be quite tricky to get owners properly on board with it all. But I do think it is something that we can be focusing on more in practice. And hopefully this gives us a bit of an easier option for those patients. Because, I mean, in terms of the injections that have been used previously, you've used it before, and are they easy to use? Are they expensive? Are they because all the non-licensed stuff, I know that people don't use for a certain reason, don't they?
Yeah, EPO could theoretically get antibodies, and the antibodies cross-react with your own red blood cells and then knock out all the red blood cells. So I think that's what it is. It's called red cell aplasia. So I think that was a risk with EPO. It was, I don't know, I've worked in clinics where the other vet had got the cat on these regular injections, and then I would do them, and they were easy to give. But I know there's a really expensive version which I've never used called darbepoetin.
Yeah.
And I don't know if you've come across that, but it's so expensive. And I think that's like longer lasting and less reactive.
I think the reason why this has sort of caught my attention is I think there's now hopefully something that we can all start using in practice and be a little bit less scared of. So the UK apparently now has its first licensed medicine specifically indicated for treating non-regenerative anemia associated with CKD in cats. It's called Varenzin. I don't know if that's how you say it, but also why do they always have such stupid names for these products? Why don't they name it something that actually makes sense? But anyway, when you have chronic kidney disease, you're not producing as much erythropoietin. So basically, you're not regenerating as many red blood cells as you should be, which is why you get a non-regenerative anemia. And it doesn't replace EPO, but instead it's from a class of drugs called hypoxia-inducible factor prolyl hydroxylase inhibitors. I don't know what the hell that means, but basically it just means that they stabilize something called hypoxia-inducible factor, or HIF.
Yeah, brilliant. Another really easy one. By the way, on the topic of why don't they give drugs proper names, how about if they came up with another JAK inhibitor and they called it Itchoquel? Isn't that a good idea? Itchoquel. Yeah. And then, like an anti-sicky drug. I don't know. Sickocalm. Yeah, there we go. There you go. Done. They should come to me.
Easy.
Sicko. Here you are. Look, I'm going to give your dog some Sickocalm. There's your itchy dog. Itchacalm. Itcha whatever. Itchaquel.
Brendan,
That's good.
This is a new revenue stream that we've just been completely missing. Honestly, totally. I need to get your name out.
Companies, come out. Come to us. We will give you the names.
Yeah.
What were you going to call this Varenzin then? What are we going to call this for anemia? Anemofix.
Yeah, there you go.
Oh, you don't like that? Yeah? Anemofix?
No, it's good.
Yeah, come on.
Yeah.
We're ready. Come on, give us more. Send in your drug names that are going to make life easy for us. Yeah, good. Okay.
Yeah. Anyway, talking about this HIF thing, and apparently if oxygen levels are normal in the body, then HIF gets broken down. So basically it means that you're not having to produce as much EPO because you shouldn't need it. Now, this medicine actually prevents that from happening. So the body then behaves as though the oxygen levels are lower than they really are. So that then means that it tells the body you need more erythropoietin because you need more because you're not getting as much oxygen. You following? So does that kind of make sense? It just means that it sort of causes the body to produce more EPO, improves your iron utilization, so to encourage the body's own red blood cell production. So rather than giving EPO from outside the body, you're encouraging the body to do it itself, which makes a lot of sense, I guess, and hopefully has fewer side effects as well. But yeah,
and it's oral medicine. I think this is a goer, isn't it? I think all those older cats, the owners might be better.
Yeah, I just think if we can be doing anything for these older, we all know the older crispy CKD cat, and it's just trying to improve their quality of life for as long as we can, isn't it? And I think if we can improve that red blood cell count for them, make them feel a bit less lethargic, give them a bit more energy, a bit more life back, it's like, what a lovely thing for us to be able to do. So yeah, bear it in mind, keep an eye on it. There we go. And something else that I wanted to mention, which I didn't actually know about until a couple of days ago, but I was doing a locum shift and I was chatting to one of the vets from the day staff as I was finishing, and he's really into his cardio, and he was saying about this potentially new really exciting concept in cardiac cases. So those SGLT2 inhibitors that have started coming into veterinary now, is it Semvelgo that we use in cats, or you can use in cats for diabetes? Have you ever heard about the concept of them being used for heart disease in veterinary patients?
No, definitely not. Hold on. How does this work then?
So basically, they think initially everyone just thought that they lowered blood glucose by causing glucose to be excreted in the urine, which is why you get those you can get DKAs that are normoglycemic. So that's sort of the issue around the diabetic stuff there. But apparently there's loads more that they can actually do. So potentially there are other beneficial mechanisms of things like they have a mild diuretic effect. They increase sodium excretion. They reduce plasma volume. They reduce cardiac preload. They can reduce afterload. They can improve myocardial energy metabolism. Apparently there's loads of these other really interesting functions that they have, and they're different from furosemide because they don't produce massive fluid losses. So that's something else to bear in mind too. So they don't put loads and loads of pressure on the kidneys by sort of pushing out loads of fluid from the body. So I think it's something that could potentially be really interesting. And basically as far as I know, there's no randomized clinical trial or something sort of really, really concrete in terms of evidence yet. But I think there was a review paper that came out that looked at potentially using it, or using these SGLT2 drugs for potentially using in congestive heart failure patients. So patients with like myxomatous mitral valve disease and things like that. And it's basically been looked at retrospectively. And people think that actually there's fewer admissions for heart failure. These patients live longer, they had improved kidney function, and they often feel better, and that they're not diabetic patients. So you're using them and it's helping with the heart disease. I don't know, there's still a hell of a lot more work that needs to be done. And I'm not saying that people should start using them straight away without more studies coming out. But in theory, this could be like the next massive change in the evidence, the next massive step and movement in CHF cases since we started using pimobendan, which is really interesting. So yeah, keep an eye out. There might be like the new version of that EPIC study. Maybe there's going to be another one that's in the woodwork that's going to come soon.
Yeah, we need it. That'd be really cool. Yeah. And we haven't had a new drug for ages, have we? So yeah, I like that. That's a good find.
I just wanted to chat about, before we finish, I just heard about something ridiculous recently and I just thought it was funny to bring up. Did you read that Vet Times article about the monkey getting abandoned on the London bus? Did you hear about this?
I saw the headline, but I never read it. Yeah. It came up on my phone, actually, I think.
Yeah. So what ridiculous people do this, I don't know. But there's this marmoset that was obviously owned by someone random in the middle of London. It was hidden in a laundry bag, poor little bugger. And they just took it on a bus and left it there. And it's like, one, why would you own a monkey in the first place? Like, why would you do that? And two, that's just horrible. Like, why would you just leave it on a bus in a laundry bag? Anyway, apparently now it's been rehomed, if you want to call it that. And the article says it's currently being cared for at a specialist sanctuary, which had itself been looking for a female companion for its own lone male marmoset. So it's quite nice, really. Little monkey love story.
Oh. I've just looked it up on Google. It says they've nicknamed it Oyster.
Yeah, it's cute.
Which is really cute.
I love marmosets because they look like little old men, don't they? They're all like fuzzy around their faces. I think they're so sweet. But anyway, there we go. Okay, round-up time. So we had that really amazing interview with Caris Animal Health. So thank you very much for sponsoring us, as we said. And if any of you do want to hear about GIQuest, then remember the links in the show notes. We had a little chat about kennel cough and got a bit ranty about that, like we always do. And remember, there might be that new CHF drug that could become, potentially, something could be coming out in the next few years, which would be really interesting. Yeah, thank you very much. It's a hell of a lot today, and we were a bit erratic like we normally are, but hopefully you enjoyed it. And remember to get in touch if you do have any comments or suggestions to help us to improve these pods for you, any topics you particularly want to cover, etc. Remember, you've got the blog, you've got our WhatsApp number and the socials to contact us through, so please do get in touch.
Yes, absolutely. But for now, thank you for listening. Join us next Sunday for our next bonus episode where we're diving into a biggie, heat stroke and SIRS.
Yeah, it is a biggie, and these are such horrible cases, but hopefully we'll be able to break them down a little bit for you and make them feel a bit more manageable. I want to say that we planned this really well, planning heat stroke for mid-August, but I can't help thinking that the bloody climate's changing so much that we actually already missed the boat, because I feel like the heat wave came like 2 months ago, didn't it? But hey-ho.
Yeah, I know, because it's been so hot. But actually, we haven't, in our general practice, I don't know why, we haven't had any heat strokes coming in yet, weirdly. I don't know. Have you been, how about an ECC? Has it been
Yeah, we've seen a few. Yeah, I've seen some really bad ones, but we'll get onto that next week anyway. So we're looking forward to covering it already. But until then, it's bye from me.
And bye from me. Take care. Is intended for licensed veterinary professionals and is provided for educational and discussion purposes only. Whilst it's publicly accessible, it is not intended as advice for pet owners.
The views shared are based on our own clinical experience and interpretation and do not replace individual clinical judgment. We accept no responsibility for decisions made based on this content, and all cases should be assessed on an individual basis.
Any references to medications, treatments, or products are made for educational discussion only and are not intended to promote or advertise veterinary medicines to the general public. Veterinary medicine should only be used under the direction of a prescribing veterinary surgeon and in accordance with UK veterinary medicine regulations.
This podcast may include paid partnerships or sponsorships. These do not influence our clinical opinions, and any sponsored content will be clearly identified.